So, hey everybody, I'm really excited today. We have our first guest on, and his name is Dr. Mohammed Alo, and he is a board-certified cardiologist from the Ohio area, known as America's Cardiologist, and he's an author. He's written an outstanding cholesterol textbook that we'll post, and you can find it on Amazon. He's a personal trainer, and just he's a friend and a colleague. And Dr. Fiorillo and I are really happy to have him on today. And we're going to discuss all things cholesterol and a little cardiology and a little lipids. And Dr. Fiorillo is going to ask a lot of questions because most of us, even cardiologists, don't know a lot about lipids. So being a plastic surgeon, he doesn't know a lot. So this is going to be an educational experience for him too. So, yeah, Mike.
This is great. So I'm sandwiched between these two very well-credentialed doctors, and it's great because most people probably don't know you have cardiology, interventional cardiology, and then you have a cardiothoracic surgeon. So maybe you guys can explain to the audience the difference between, because you guys both at the end try and do the same thing, save lives, help people with heart disease, but you do it a little differently. So maybe you guys can each explain the difference.
So, hey, thanks for having me on. I appreciate the opportunity. So a cardiologist is someone who treats patients long-term. You see a cardiologist when you have high blood pressure, cholesterol, or diabetes is difficult to control, a valve that is leaking, atherosclerosis, you might have had a heart attack or stroke or stents or post-open heart surgery. You go see Dr. Mike and he does surgery on you, replaces your valves, open heart, bypasses some vessels. And then you follow up with a cardiologist. They'll usually see you once or twice afterwards, kind of make sure the wounds on your chest have healed up and make sure there's not anything going on. And then you follow up with a cardiologist generally for the rest of your life. As a cardiologist, I would like to prevent this as much as possible. And luckily today we have tools and medications and therapeutics that can help us prevent heart disease almost completely, which is one of the reasons why I wrote the Cholesterol Truths book, because there's a lot of misinformation out there. People telling you that you should have high cholesterol and it's okay and it's not a big deal as long as you're healthy and as long as you're whatever it might be, that high cholesterol is not a problem, when actually, in fact, it is the problem. We've had over 100 years of data now on cholesterol being the cause of atherosclerosis, and it has met the criteria for causality over and over and over again. High cholesterol causes atherosclerosis. There's nothing else. People want to blame it on inflammation. They want to blame it on sugar. They want to blame it on their mom or their grandma, all kinds of nonsense. And it turns out that regardless of anything else, whether your inflammation is high or low, or your sugar is high or low, or whatever it might be, at the end of the day, if your LDL is high, even if you're 20 years old or even 5 years old, some of these patients that have 5 years old, that have these genetically insanely high cholesterols, they will have heart attacks and strokes by age 5.
I've operated, Mohammed, on, I think, a 22-year-old, who had familial hypercholesterolemia. I just want to backtrack a second. So the reason Mohammed and I have basically taken an interest a long time ago on what's called lipidology, which is fancy term of managing your cholesterol and your triglycerides and everything. It's not really formally taught in training. So, we both have an expertise in it and have developed an interest, and a lot of it is self-taught. So, a lot of people wonder, and a lot of my patients are like, how come your average doctor doesn't know about it? And it's because they don't teach it, and if they do, it's in a very cursory way. So, that's the interesting fact. So certainly they didn't teach it in general surgery, and in cardiothoracic surgery, we're just more interested in operating, and doing the bypasses. And, what I say to people is the difference between me and a cardiologist. The cardiac surgeon is the one who touches the heart, who actually holds the heart. The cardiologist sees the heart, either sees it on pictures or echocardiograms and stuff, and who, there's very few cardiac surgeons, like you said, who treat the whole patient.
And it makes me crazy, and I'm sure it makes you guys even crazier, is that we have the number one killer, right? Heart disease. And yet when you're on any of the social media platforms, you see statins are bad for you, Cholesterol's fine. Actually, it's good for you. You should have cholesterol.
Right.
Statins cause Alzheimer's and dementia. They lower your testosterone, all bad stuff. And you should be eating fats and butter and eggs and egg yolks. And so there's so much misinformation out there.
He goes batshit crazy, Mohammed. Seriously, every morning, like this weekend, we didn't really talk, Mike and I, and it actually kind of felt good, even though I love him. There's not a morning that I don't wake up where he sends me some batshit crazy thing.
I love sending him that stuff.
And then I wind up getting in a fight with somebody online, and I'm sitting there, and then I think about you, and I'm like, just don't engage. Mohammed doesn't engage.
Well, it's one after the other. And but the thing that gets me crazy is people really believe this. I know a lot of people, especially at my club, that stopped their statins. They just stopped them cold turkey. So I think this is great. Let's provide information. And listen, we don't know everything, right? But we know what the studies show, and that's all we can.
We definitely know a lot. I mean, a lot of people are like, well, you don't know. Medicine evolves every day. But there are certain things that are very well established. Like, for example, the causal role that LDL cholesterol plays in heart disease is one of these things that is extremely established. There's not going to be any data in the future coming out that is one day going to disprove this.
Right.
That's just not even possible. There are certain things that we absolutely know that is not going to change. We might change a little bit. Like, in the past, we're like, oh, maybe oxidize or maybe the smaller ones. But it turns out, no, none of that is true. 10, 15 years
this
later.
is the most studied topic in modern medicine. What I tell people is, I believe, don't quote me on this, it was either 1769 or 1739. Cholesterol was first identified in gallstones. And then in 36 or 33, cholesterol was first identified in the body. And then you remember Anchikoff, like in 1909 or 1911, when they fed rabbits high cholesterol, and they caused rapid atherosclerosis, which is blockage of the arteries. So when these people say this stuff, I lose it. You're much more calm than I am. Like, I lose it because...
Well, I don't know. I've never seen what you post. They're crazy, but it's like a constant barrage. Like, people send me videos literally all day and all night. Like, you need to respond to this one. You need to respond to this one. You need to respond to this one. And I can't respond to all of them, but I respond to the most egregious ones. And they're almost always saying the same thing. They're like, well, it lowers your testosterone and it lowers your cortisol and your hormones and this and that. And they're just trying to sell you some nonsense. Like, none of these things are well, usually it's supplements. Usually it's like
supplements or products.
Oh yeah, supplements. Yeah, so products. They're usually trying to sell you something that, like, how I cured, like this lady yesterday, how I reduced a blockage of 70% to zero in a matter of months. Like, why aren't we calling in the National Guard? If this lady was able to reverse a blockage of 70% down to zero in 2 or 3 months, how come no one else in the world has heard about this? Why aren't we, like, calling the president of the United States and the European Atherosclerotic Society and all these people to come and, like, figure out what this lady's discovered that all of cardiology hasn't been able to discover?
Didn't when we talked the other day, I said this to Fiorillo once, but didn't I say to you the other day, it's like, people think, like, you guys, when you have your meetings, you go in the rooms and you're like, hey, I know how to clean out the arteries. Don't tell anybody. Like,
right.
And I say to people, listen, guys, if
we knew, we would be taking it.
No cardiologist or heart surgeon would be dying of a heart attack.
Right.
If we knew,
yeah, I mean, it's they think we have some magic that we're hiding, or they discovered some magic. I mean, because, like, people are really gullible. I mean, even doctors. I mean, I work with some physicians who hear and they're like, what do you think of this study? And they'll forward me something about, it's okay to eat saturated fat. Some guy that's a known conspiracy theorist does some state-of-the-art review, which they think is an actual study, which it's not. It's somebody giving an opinion, citing, some other studies, and they just give their opinion that, well, maybe the data isn't really there. And it's just a guy's opinion. Like, state-of-the-art review doesn't mean anything. It's just an opinion. Where you look at the data where people were overfed saturated fat versus not, versus replacing even 5% of it with non-saturated poly or mono unsaturated, the data speaks for itself. You don't need to opine or think about it. We actually have data that shows that saturated fat is a straight line to all-cause mortality, cardiovascular mortality, heart attacks, strokes, every horrible thing you can imagine.
But where that took hold. So, Dr. Oz, who at one point, he interviewed me for Columbia University for the residency, he was legit and he knows better. Okay. Like he knows the deal. And when he sold out, his whole line was that saturated fats raises your HDL and your LDL, but the ratio of raising it is good. So therefore it's not bad for you. And I was like, wow. I go, this is so bad because he knows the truth. He's a heart surgeon and he was the real deal. And, you know, and he sold out.
That's just idiotic. That first of all, it doesn't raise your HDL. That's nonsense.
Right.
And also no amount of looking at HDL to LDL ratio is going to help you. I mean, we used to think that 15, 20 years ago.
Well, you know, that's a good segue. So why don't we go into, so the regular person that's listening, everyone knows the lipid panel, right? The basics.
Right. So
why don't we review that? So I'm a 50-year-old guy. I go in for my yearly physical, and my lipids come back. What should I be looking at?
So Mohammed, do you want to
lipid panel?
Why don't you explain total?
So I'll tell you how I look at it, maybe.
And I'll talk about HDL cholesterol. You want to talk about triglycerides?
Sure. So I'll tell you how I look at it from a cardiology perspective. So in the past, we used to think HDL was protective. Some of the original Framingham data showed that some people with higher HDL maybe didn't have an issue, but when it was corrected for LDL later and ApoB, even after that, it turns out that HDL almost plays no role, whether it's low, high, medium, insanely high, or insanely low. There was no correlation at all with cardiovascular risk. However, they found that LDL cholesterol does. The only reason really to get a lipid panel today, mainly is to get a fasting triglycerides. There's almost no reason in today's modern world, when we have ApoB, which maybe we'll get into later. I don't know if that's on your list, but right now, LDL cholesterol is not an actually measured lab value. There's no such thing as actual LDL cholesterol. You are calculating it. You're taking your total cholesterol, which is the total cholesterol inside of all of your lipoproteins, your LDLs, and these are lipoproteins. I don't know if you guys have video, but these are lipoproteins.
I have them, but I haven't I haven't pulled them out.
Inside is the cholesterol. And when you're measuring total cholesterol, it is the total amount of cholesterol in every lipoprotein in a deciliter of blood, which is your high density, low density, very low density, and intermediate density. Now, the majority, the HDLs are easy to take out. They're very small. They're 27 times more HDLs than LDLs. But those ones are easy to take out, when they do the centrifuge or the immunoassays that they use now. The rest is what's left over is like triglycerides. And then they take triglycerides divided by 5 and they subtract that out too. So it's total minus HDL minus triglycerides divided by 5. That's called the Friedwald equation. There are more accurate equations that they use now. There's like one called Simpson's or something that I believe, not Harvard, the other one. Anyways, there are other ones you could use.
There's another. I mean, I just basically tell people to simplify what you said because you flew through it. So first of all, total cholesterol, to make this really simple. Total cholesterol has never been written into one guideline. Okay. So regardless of what people think, because everybody's walking around and saying, well, my total cholesterol is less than 200 and my HDL is high, I'm good.
Yeah, that's
right.
And
if that was the answer, we know how to raise your HDL cholesterol. Okay.
But also that's problematic. That's also a problem because the new guidelines want your total cholesterol under 150. And actually, total cholesterol in and of itself is not a goal of therapy. No guideline says
that's what I'm saying. Nothing has ever been written.
Total. Right.
Right. So total cholesterol, what I always explain to people, Mohammed, is so it's the equation, like you said, it's your LDL cholesterol. So your bad cholesterol plus your good cholesterol plus your triglycerides divided by 5 if they're less than 150. So I always go and I say to people, okay, so you walk in and I'm just giving, so the normal HDL, let's say is 40. So, and your total cholesterol is 200 and your doctor says everything's fine. Well, now if your HDL cholesterol instead of 40 is 80, that's 40 points higher. So now your total cholesterol is 240. So your doctor's scratching his head and he's like, your total cholesterol is 240, but your good cholesterol is high. And they don't know what to do with it. So I always tell people just like, forget about your total cholesterol. We're not even going to look at it today.
Yeah, forget total and forget HDL even. I mean, we have no reason to even look at HDL. But like I was saying, kind of just to finish up on the beginning part of this, the only reason you need a fasting lipid panel today's world is triglycerides. If your fasting triglycerides are over 500, you have hypertriglyceridemia.
Right.
There are lots of things that can cause that we need to treat rather quickly, especially if it's in the thousands, because you could end up with pancreatitis, which could lead to pancreatic cancer. There's all kinds of horrible things that could happen with a fasting triglycerides that is that high. So that's really the only reason we need that. The rest can be easily figured out with an apolipoprotein B. And again, if we look at these lipoproteins, rather than trying to guess the amount of cholesterol that's in it, if you just measure the structural protein in plasma, you get a concentration gradient of how many particles you have.
Have you seen that new data that shows that regular lipid panels should be done non-fasting because fasting is not a physiologic state? So you're going to get a more accurate result.
You could. I mean, you could definitely argue for that. But the issue is the triglyceride, as long as, because you want like a bit, like when you tell somebody go get a testosterone check, you want it first thing in the morning. Like it hasn't had time
to I agree.
fluctuate
but my thing
and go up and be affected by your daily life. But in most cases, I would say an apolipoprotein B, fasting triglycerides, or even a random triglycerides, I suppose, and if that's what you want to do.
Right.
I think that gives us the majority of someone's risk as to whether or not, and the final marker, the third one I would say is lipoprotein A.
So I just wanted to back up for a sec, just because Mohammed went through lipoproteins and showed you that little sphere really quickly. So as most of you know, who are my patients or who listen to me, I made that analogy a long time ago that called the Richman analogy. And is it the number, you remember what it is? Is it the number of cars on a freeway that cause a traffic jam, or the number of people in the cars? And when we're talking about your LDL-C, the traditional way, those are the people, okay? But what's important and what causes atherosclerosis is the number of cars. So what he showed you was a car, and inside that car are the people. So we know the more people, the more cars you have, in other words, the higher your LDLP or your apolipoprotein B, the greater your risk, okay? So that's what we're talking about. So that's the goal of treatment. Now, next, we're going to move into something which I'm sure a lot of you have heard. Mike Fiorillo has asked about it a lot, is something called LP little a. So people are concerned about it. So we'll let Mohammed first talk about LP little a, and then I'll chime in.
So lipoprotein A, I would say, is probably the third test. Like if you were going to get, three tests, the third one is this lipoprotein A. And, so you have your normal low density lipoproteins. Sometimes you have this thing on it called a kringle, and the liver makes these and they attach to low density lipoproteins. The kringle can make your low density lipoproteins 3 to 6 times more atherogenic. And this is a lot of times when you see a younger patient who's having aortic valve replacement, like their aortic valve is way too tight, they got calcified too early, they don't have any of the traditional risk factors, they're not a smoker, they might not be hypertensive, diabetic, they might not have anything other than they're like 55 years old and their aortic valve keeps getting worse and worse and worse. They're going to have to see Dr. Mike in a bit here to have their aortic valve replaced, but they get early onset calcified aortic valve and atherosclerosis, obviously the same process, atherosclerosis in the arteries. It would be important to check that too, because if you have this, we can screen your children, your parents, well, not parents maybe, but siblings. 25 to 30% of people have this, but 0.1% of people ever get checked. So it's very important to also know that number, not just for yourself to protect yourself, but also to know if we need to screen your kids. And if you do have that number and you've never had a problem, like sometimes I get a lot of patients who say, hey, I saw one of your videos and I want to see you. I got this LPA checked and it's high. What should I do? And then they'll come in. They've never had an event, never, their aortic valve's still fine, all of that. These are people that are super high risk. We got to get their LDL cholesterols down below 40. And the lower, the
their
better.
lipoproteins.
Their total LDL, their LDL particles or cholesterol, however you want to measure, ApoB, even down below 40, because that offers the most protection against destroying your aortic valve and or arteries, brain arteries, dementia, whatever even. So that's one reason why we do need to check that.
I mean, remember everybody, if you drive your lipoproteins way down, way down, by and large, not going to say always, but you can put your money on it that you're not going to have a heart attack or stroke, okay? Because that is what causes atherosclerosis, which is blocking of the artery. Okay,
And how do you
that's the
get
main
those
thing.
down? And how do you get
Okay,
those?
interesting thing. So, the treatment is, as we just said, to drive your apolipoprotein B or your LDLP very low. Yes, Mohammed will talk in a sec. There are a couple medicines that are promising that drive your LP little a down.
Yeah, so there are lots of drugs that can lower your LDL cholesterol, and we know that those improve outcomes. Everything from the statin class to ezetimibe to the PCSK9 inhibitors to bempedoic acid. I mean, that, we know. I think what you're asking is mainly for lipoprotein A.
Protein A, right?
There are about
Yeah.
5 medications in the works for lipoprotein A. They all really reduce lipoprotein A, 95%, 85%, 75% reductions in lipoprotein A. They're in trial. Until they demonstrate an outcome benefit, like they reduced heart attacks or strokes versus placebo or versus other people medically optimized, then they're not going to be approved, because why would you want to put somebody on a, let's say, $20,000 medication a year for something that it's not going to prevent one heart attack or stroke over a standard of care,
Right.
which are cheap generic meds. The other meds are mostly cheap and generic at this point. Why would you approve a medicine that
Right.
does almost nothing?
So it's
that we
just like
already have?
it's the same concept as raising HDL. It's just you're raising it in its futility. You're not changing the outcomes.
You're making the numbers look pretty for no reason.
Right.
The other thing that's interesting about these lipoprotein A trials, one of the ones from this year was supposed to end this year, but there wasn't enough events that occurred in the trial to show an outcome, which is actually sort of good in a way, because that means we know that if you treat people with traditional meds to get their LDLs down to very low levels in the single digits, or 15, 20 at the most, we know that prevents events, because not enough people had events. So they extended the trial an extra year to see if we can find an outcome.
Which you just made an interesting segue. So how Mike, because you asked me, and you also see it all over social media, your LDL cholesterol, you're driving it down too low. So therefore, your brain is not going to have enough cholesterol, and you're going to get dementia, and then your sex hormones are going to go too low. And guess what, everybody? So the majority of cholesterol is made in your liver and your small intestine. And yes, we can shut that down on a macro level, but every cell is capable of making the cholesterol it needs to function. And your brain cholesterol is independent of your total body cholesterol. And so the life of a lipoprotein particle in your body is about 3 days. Your brain cholesterol lasts for 6 months to 5 years. Okay, so it's absolutely opposite. It's like, you want to drive people's cholesterol way down, because that has been shown to decrease dementia. And you can talk about that, because Mike is just, he gets that from everybody at his country club, right?
Yeah, well, not just that, but it's all over social media. We all see it. So, and when I tell people it's quite the opposite, they're shocked. So, there's really good studies that show indeed it actually can lower dementia risk. And there's so much cholesterol in your body, you're not eliminating it, you're just lowering it.
Correct.
Yeah, so these are all really good.
Around.
These are all very good myths to dispel. And the reason my book is called Cholesterol Truths is because there's a lot of books called Cholesterol Myths or Cholesterol Con or Cholesterol whatever. So each one of these topics that you guys just brought up about the testosterone and the dementia and the cancer risk and the hemorrhage risk and all of that, how low is too low, all of those are chapters in the book. So let's hit it, right off the bat. Every cell in your body makes cholesterol. So now the question is, can you ever have cholesterol being too low? So the 4-year trial and the 4-year OLE, open label extension, this was the Repatha trial. They looked at people who were already medically optimized, already had like LDLs 60 to 70, at goal, added Repatha, smashed these people's LDLs down even lower. The lowest group, 9% of the people in the 4-year OLE trial had LDL cholesterols in the 0.2 millimole range, 0.2 millimoles per liter, which in Americans like 7, 5, 7. Their LDLs were like 5, 6, 7.
Well,
really
tell him what normal is if you follow guidelines. So he's saying 7. Normal, if you look at normal guidelines, less than 100. Okay, so normal guidelines would be.
This was in the single digits. This was like 7.5, maybe somewhere in that range. So the people in that category of people that were followed for those 12 years, and they're still being followed, They did not have brain hemorrhage, side effects, more side effects, any of that. What they actually did have is more reduction in cardiovascular event rates, less heart attacks, less strokes, less cardiovascular mortality. All cardiovascular endpoints improved even further. So there was no disadvantage to having an insanely low level, like 0.2 millimoles per liter is an insanely low level. Like I said, in American, that's like 6 or 7. So very, very low. The other question that comes up is what about testosterone? So your body, all the cells in your body, including your adrenal cortex, your estrogen producing ovaries, and your testicles, all make their own cholesterol and eventually testosterone, progesterone, estrogen, cortisol, whatever. All you need is a citrate molecule and an acetate molecule, which every cell already has. And then it's like a 27
Hmm.
step process to make cholesterol and then vitamin D or whatever hormone you're thinking of. And there's no way to stop that. And even if we drive your LDL down to almost zero,
Hmm.
there's no case where your testicles run out of substrate and need to take cholesterol out of your LDLs. That's just not how it works. Same with all your rest of your um,
Right.
hormone producing, and they call them steroidogenic tissues. All the steroidogenic tissues can make their own cholesterol without a problem. Your brain, like he said, makes its own cholesterol, and there's no cross contamination. These
Right.
circulating lipoproteins, these things in circulation do not cross into your brain at all. Your brain makes its own cholesterol, does not need any lipoproteins from circulation. There's the blood-brain barrier; it keeps it out. The brain cholesterol has a very long half-life. Some, especially if you're like a 20-year-old or 30-year-old, some of the cholesterol in your brain has been there since infancy. It's a very long half-life, so a lot of it doesn't go away. And your brain can make its own. Lipoproteins do not cross
Right.
over at all, especially not the low-density ones. So those ones, and so there's no really cross contamination. There's no evidence that lowering LDL actually causes any dementia or Alzheimer's. In fact, a recent large meta-analysis has been published with 7 million participants followed for 35 years and all that stuff. They found that statin medications, those on statin, have had a significant reduction in all forms of neurodegenerative disease. This is like dementia, Alzheimer's, Parkinson's,
Yeah,
MLS,
we
or
talked about it.
ALS,
So
multiple
that's
sclerosis.
the meta-analysis of 55 trials, 7
Yep.
million
Right.
people.
We've talked about
And
that
I
before.
think it was, I want to say it was all-cause dementia. I want to say 17%
Right.
of all-cause dementia. And 7 million people don't lie, and that's,
Yeah,
but
and not only that, but this is in addition to multiple other studies that have been
right,
done before. So this is not like a standalone trial. They also had a recent study published where they looked at statin and cancer. They found that people on statins, depending on which statin, had a reduction in multiple different types of cancer, even. And they
yes,
found mechanisms of how this happens. And I've published these on multiple videos and on my blog and whatever, with the cool graphics and the studies and the live links to the studies. Reduces multiple different forms of
right,
cancer through various mechanisms. A new study that just came out a few days ago looked at ezetimibe. Ezetimibe in and of itself reduced Alzheimer's. So the Lancet
right,
about a year ago in 2024 said that the number one risk factor for Alzheimer's or dementia or anything is high LDL cholesterol. If you get
right,
that down, that in addition to like hearing loss and visual changes and other issues, frailty, whatever, contribute a lot to Alzheimer's. But the number one risk factor right now is LDL cholesterol. So anything that lowers LDL cholesterol will contribute to improving or preventing, let's say, any form of neurodegenerative disease, which is very debilitating. Not to mention like
Great.
microvascular stroke reduction. Like obviously the arteries that go into your brain are similar to the arteries that go into your heart. Strokes and heart attacks, that's all given. Like we've already known vascular dementia and vascular, heart
right.
disease, peripheral artery disease, all that stuff is 100%, LDL caused. Now we know that some of the other things may be.
So now that I think we've really explained that, and hopefully there's no more questions on that from at least people listening to us. I think we should move on to the other one because everyone, gets their lipids, but then everyone says, "I had my calcium score at 0. I'm good. I'm fine." And a lot of these people go on to have heart attacks, and they don't understand that. My calcium was 0 or 1, and I had a heart attack. So I
Oh,
think that's another good one that you guys can quickly go
okay.
over because everyone asks about that.
Okay. So
So no,
you
go
want to
for it. Go
start
for it.
or you want me?
No, go
You
ahead.
want?
You give yours and then I'll give you mine.
Okay. So first of all, I'm not a calcium score guy. So let's understand everybody. First of all, there are two types of patients. There are patients that are symptomatic, and I'm going to really dummy this down. Symptomatic and asymptomatic. So symptomatic means you're having symptoms: chest pain, shortness of breath, fatigue. No patient who's symptomatic should ever have calcium scoring. Okay, so let's take the asymptomatic patient. If you follow the guidelines, which I don't, the guidelines say if you're moderate, high, or high risk of a cardiovascular event, and we don't need to get into how you determine that, because I also think it's totally inaccurate. But
and I agree, by the way.
What?
I think the guidelines are way too loose. I'd rather be stricter, but we'll get into that later.
Okay,
maybe.
So if you're moderate, high, or high risk of a cardiovascular event, and if the presence of calcium will upstage you to a higher risk, you can do it as a one-time study. Okay, now what they don't tell you is, number one, there is nothing that causes regression of calcium. In other words, like we talked about earlier, if there was a way to pull calcium out, we would know and we would do it. Okay. And more importantly, the guy who was instrumental in developing calcium scoring, by the name of Matthew Budoff, he wrote an article early on, I believe it was in 2011, who said the absence of calcium does not preclude total obstruction of the coronary arteries. Well, I'm telling you as a heart surgeon, the majority of the coronary arteries that I feel have minimal to no calcium. So they have what's called soft plaque. So in other words, as I tell people, just like kids in bones. So when something's immature or young, just like kids' bones, they're not calcified. So these immature plaques, and these immature plaques, these are the people who you hear who run a half marathon on a Sunday and drop dead on a Monday. And everybody's like, poor bastard. He was in great shape. He died. He had a rupture of a soft plaque that probably had zero calcium. People who have high calcifications, like, we know this. So to me, it adds absolutely no value. Now, one thing I told Mohammed, and then I'll let him go. So my go-to is Ray Matthews. He's the chairman of cardiology at USC, who's one of the early angioplasty guys who's excellent. And, I've asked him numerous times, Ray, who do you get a calcium score on? And he says, the person who will not take medicine, who I know is going to have a high calcium score, who needs to see the calcium to be convinced that they have atherosclerosis. That's it. Okay, so that's my little take on it. Now, your turn.
So as cardiologists, we read these scans all the time. I mean, the calcium score is pretty standardized, through the algorithm and the computer, but the CT angiograms and all that, we read these. The problem with calcium score is that it's testing for late stage disease. The example I give is that if you had a smoker and they'd come to you every year, you see them in clinic, and you're like, let's do a CT scan, see if you have nodules, maybe you have lung cancer. You do a CT scan, it's fine. Would you tell them, you're good, keep smoking? No, that literally would be insane, right? And then they come back next year or like 2 years later. Oh, you're still smoking? Let's get another CT scan, low dose CT scan, no nodules, no cancer. You're good, keep smoking, no big deal. It's like not a problem. Keep smoking. No, wonderful. Your lungs are strong. You got strong lungs, good genetics. Like, that's literally, you guys are laughing because you think I'm insane right now, but it's literally what calcium scans are doing to our field. People go get a calcium scan. Like, these people pay for it themselves. It's like $100. They go to Life Screening, and those people are scamming them. But you go to these scam places like, come get your lifelong screening, whatever it is. They do a carotid and a bunch of blood tests, and they do a calcium scan, and they tell you your calcium score is 0. You're like, yes, I'm good. That means I don't have heart disease. Not to mention you got like a 90% LAD blockage and a 30% circ and diag. And like, you've got all these blockages everywhere. They're just not old. They're not calcified, and they're not going to show up on
just like what I said.
Yes,
right.
Exactly. And it's a bunch of nonsense. We know from the PISA trial, the Framingham trials, multiple trials now, if your LDL cholesterol is above 60, you are laying down plaque. And it starts at teenage years and it keeps going.
Starts at birth.
Yeah, it starts at birth.
Because I talk about, and the study, that the mummy study, which I always talk about. Yeah. So there was a mummy study, and it was 126 mummies spanning 4,000 years, and they found that 34% of mummies had significant atherosclerosis, including women and children from South America who were vegan. And then I also wrote a paper on.
And don't forget, mummies died at age 42. Like they
Right.
did not live to 70s and 80s.
Right,
They were
exactly.
dead by 35 to 45. So these are young people with atherosclerosis.
Right. And I also wrote a paper on, they have done multiple studies. They looked at the autopsies of Korean war dead, Vietnam, Iraq, and Afghanistan, men between 18 and 35. And I forgot which war because it's gotten worse, but in one of them,
Vietnam.
I want to say 64%, maybe even higher, had significant atherosclerosis. So the bottom line is, this is why I don't like risk factor scoring, and I think it doesn't help, because we all have atherosclerosis, all of us. Okay. And the bottom line is,
and Mike, don't forget too, I saw a paper the other day about all this radiation, and this radiation has consequences as well. So, it just adds to the radiation, your total radiation exposure too. And I think there's a pretty high radiation with the CT angio, or,
CT
you're
angio,
definitely getting radiated. Absolutely.
And
Both
not
of
all
those, the
machines,
calcium
not
and
all
the CT
machines are
angio.
standardized. Yeah.
and calcium score, right? Exactly.
Yeah.
So
And
those are two things.
just to add to what Mike is saying, they've done studies on moms who had miscarriages. If their cholesterol was like 300 and they miscarried, they looked at the aortas. They already had fatty streaks in their aortas. I mean, the babies, like, in the mom's
Womb.
uterus before
Mhm.
they even have their own cholesterol. So this is not a joke. And the most recent trial, these crazy keto people ran their own trial with Buddha.
Oh yeah, tell them about this, because this is one of the things. I'm just taking you backward a second. So everybody, you're going to see right now, it is one of the hottest things on social media, and the influencers are running with it. I haven't really brought it up with you, Mike, that much, because you'll have a meltdown. But these guys are using this study, which Mohammed's going to tell you about, to justify keto and carnivore diet. Like, just go wild, eat as much meat and fat as you want. So why don't you
Listen,
tell
this
them
has been
about
around
this study?
since I was in med school. So when I was in med school, we had Atkins, and it was
Atkins,
originally his manuscript, and people were doing it, and they were saying it's actually lowering my cholesterol. Remember that? And they were eating just meat and eggs and bacon, and just that's it. And it was saying it was lowering my cholesterol. So you guys should talk about that.
Okay, so now we're going to talk about this study that is just blowing up social media, where all these people are saying to eat as much meat, carnivore, in keto as you can. And it's called the Keto CT Angiogram Study. And Mohammed's going to tell you exactly what it is and how they have basically duped everybody.
Yeah, so there was this trial. It was run by 3 people that are not clinicians, they're not lipidologists, cardiologists, or anything. One's like a statistician, one's like a software engineer, and one's like a medical
student.
Right. And they basically wanted to run their own trial. It's like self-funded. They wanted to run their own methodology, their own everything. They're all keto people. They love keto. They love high cholesterol. They love everything. So they wanted to run their own study in their own way, with their own funding, without pharma, without industry, without whatever. They co-opted Matthew Budoff, who I feel sorry for him. It seems like they, pulled the curtains over his head and told him a bunch of nonsense. But either way, regardless, they ran their own study. They had these people with insanely high cholesterol. It's like 270, I think, was the average of the LDL. And they had some people up in the 500s, 500 range, 300s. And so these are people, and they wanted to see what would happen in a year of, a CT angiogram pre and a CT angiogram later, and to see what would happen in that 1 year span. It's well designed. I originally didn't think that you're going to see a huge difference in 1 year, because atherosclerosis takes decades to develop. But these people had insanely high cholesterols, which was obviously, what drove this. And what they found was that, almost every single person in the study, other than one, had increase in plaque volume. The average plaque volume increase was 18.8 millimeters cubed. They didn't release the primary outcome. They kind of tried to hide it, which is obviously very unethical, because they didn't like the results, because it was like 4 times higher than any other study that's ever been done. When you compared it to studies that have been done on Matthew Budoff's scanners with his algorithms, with his own same software, they had a 4 times higher plaque increase in that one single year than any other study that has ever been done. And when you compared it to other CTA trials where they looked at people's, progression of plaque over time, these people had some of the most insanely fastest, rapidly growing plaque ever. Some of them had 150% increase in atheroma or plaque volume in that year, which is just horrific.
Which is insane. But Mike, what's even more insane is that one of the premier journals published it, okay, with this preliminary data. And Matthew Budoff, I mean, he's destroyed because he's UCLA Harbor guy, okay, cardiology, who's like one of the, and his mea culpa is that he didn't see the data that was published. It wasn't supposed to be published because it totally tarnished his reputation now. Okay, so these guys are all running with it.
No, but that's not the problem. The problem is they're running around telling people that LDL cholesterol did not cause this, and ApoB and LDL did not correlate with atherosclerosis. The problem is it's only like 80 or 100 people total in this study. It's not powered to show a difference. Plus, you're taking somebody with an LDL cholesterol of 370 and comparing them to 470. Like, these people are already in the 99th percentile of the highest cholesterols in the world. You'd have to have a study of hundreds of thousands of people to power for that, and they didn't. You're looking that's like comparing somebody who smokes 30 packs of cigarettes a day to somebody who smokes 40 packs of cigarettes a day, and saying the number of packs of cigarettes made no difference in how fast their cancer progressed. Like, it's insane. They're already smoking more than anybody has ever dreamed of smoking. So that is a huge problem. And then they told Matthew Budoff that the results showed no progression in plaque. I don't know how they came up with that. It's just a straight up lie, because literally every single person in it progressed quite rapidly, other than one, which was probably just due to, some kind of artifact or whatever in the scanners, who knows. But they told Matthew Budoff this. He goes on these interviews, makes a fool out of himself. And then when he's confronted with the truth about the study that was published in his name, he just kind of backtracks, looks really lost, asking them, what draft was published? What do you mean? I never seen this before.
Right, exactly.
Like, this is your own study. This is your study. You published this.
So he's MIA now. He's MIA.
Yeah, he just disappeared off social media.
So as heart doctors, what would you tell people that, eat a lot of red meat, like to have eggs every day? How do you educate people? What should they be eating? What diet do you recommend? That kind of stuff.
So generally the diet, and then there's a whole chapter of this in the book too, but like the diet that is recommended is either a Mediterranean style diet that's balanced, or a DASH diet. DASH, the only difference between that is like no salt, no alcohol, just to keep your blood pressure down. But a Mediterranean style diet is like fruits, vegetables, nuts, legumes, whole grains, lean meats, low saturated fat, use olive oil and vegetable oils rather than, butter, bacon, lard, ghee, tallow, whatever, coconut oil. So that's usually what we tell people to do. And as long as it's calorie controlled and you're.
So also I'm going to talk about a couple things that Mohammed and I are not big testers. So what don't you need? I will tell you 3 things that I do not do. I do not do C-reactive protein, even highly specific C-reactive protein. I do not, and I've written about it, and actually I did an IRB 2-year study relating to homocysteine, and you will see now, especially Gary Brecka is selling a $599 MTHFR gene testing. Remember, I did a short about that. So you don't need homocysteine. Lowering homocysteine does not alter your risk. And you also don't need MTHFR gene testing, because as I found in my 200 people, even people that had a polymorphism were not deficient in folic acid. And then the final test that I don't get is I don't do ApoE testing. Some people do, but I don't do ApoE testing.
Well, this is the whole functional medicine, chiropractic inflammation. It's inflammation in your body that's causing all these things, right? So why don't you guys discuss that? Because
let comment on what I did.
Yeah, no, I agree completely with what you said. The people with the MTHFR, like you said, they don't have a folate deficiency, and it's not a Problem, he just does that test because a lot of people come back abnormal, and he can throw them on his supplements for life.
Right.
And he's made
If you
millions
have a
on it.
test, if you have a
He's made
test where
millions.
like 30% of the population are abnormal, you start putting them on your supplements. Half the world's population is taking your stuff for the rest of their lives.
Well, he said that on Joe Rogan, that it was the single most important thing you can do in your life is to get medication.
Right. You know, he's selling them, Muhammad, $599.
Yeah,
Yeah.
$600.
So don't take real medications at work. You just need to take his stuff.
Right.
Yeah, that's wild. No, so a lot of people think that you need a CRP or a homocysteine or a uric acid, IL-6, IL-1, TNF alpha, whatever, all these inflammatory markers. There's no data to support that, and the guidelines don't have that in there. You do not need to check a CRP on anyone. You don't need to check a homocysteine on anyone. Like if somebody's LDL is high, whether their CRP is 0.1 or 100.1, what difference does it make? You're going to treat their LDL regardless. You don't need to know if it's high or low. The like LDL in and of itself is inflammatory. So if you get somebody's LDL down, in most cases, their inflammatory markers go down.
Right.
Like the Jupiter trial showed that. And the Jupiter trial was looking at that people with a semi-normal LDL. What happens if you put them on Crestor 20? And if they had a CRP over 3, which is, pro-inflammatory, they found that, they all benefited, obviously, and the CRPs actually went down. It was unethical to continue the trial because you should have put everybody on Crestor 20.
Crestor 20. I mean, what I tell people, Mike, is unless you have a lipoprotein enter the wall of the artery and start releasing cytokines, which starts the inflammatory process, you're not going to get this inflammation. So when people keep saying,
but
it's
even
all
that,
about
it's
inflammation.
inflammation inside the arterial wall, which
Right.
cannot be measured. And it's the
Right.
same thing with these oxidized LDLs.
I was just going to say that.
There's no reason to order
up.
oxidized LDL. It's just a bunch of nonsense. An oxidized LDL particle is taken out instantly by the immune system and liver. There's no correlation between oxidized LDL and atherosclerosis whatsoever. But these are functional medicine, chiropractic nut jobs can sell you a bunch of tests. NMR, you could argue.
I'm so glad you brought that up because if I see oxidized one more time, because oxidation takes, obviously your body removes them, but oxidation takes place inside the wall of the artery. You cannot measure it. So
right. And the same thing with they want to order all these particle sizes. It's the big LDLs or the little LDLs. They're literally exactly the same size. There's
the fluffies.
The difference between the biggest LDL particle and the smallest is like 5 nanometers. I mean, come on, really? And they're both so tiny that they both get in. Like anything under 70 gets in.
Yeah.
And you're talking about an 18 versus 22. They
right,
both
Mike.
get
So
in.
the hole remember I told you the hole in an artery wall is 70 nanometers. Okay.
Yep.
So the largest particles are like 24, maybe. Okay. The smallest are like 18. So anything in a high concentration is getting in the artery wall. And then when they start talking about fluffy, like I had a dog named Fluffy, when I was 10, and they're sitting there, well, you want fluffy, the fluffy pattern. And I'm like, what the hell is fluffy? So none of that crap matters.
No, I agree. They just don't understand. I think a lot of the problem with the internet is that it democratizes information. Literally anybody could start a TikTok account or YouTube account and say almost anything and sell some stuff. Sell testing, sell, supplements, gene therapy, like a bunch of bullshit, Oh, I don't know. Sorry, I don't know if I can say
No,
that,
it's fine. I'd say bullshit all the time.
A bunch of stuff, selling a bunch of stuff that people don't need, but they can scare you enough into thinking you need it. And then people all of a sudden think they're not being treated by their doctor correctly because they didn't check a homocysteine or a fluffy oxidized whatever the hell particle.
People are so quick to think the doctors don't know what they're doing and big pharma is a scam and they want to keep you sick and all this stuff. So
right.
I think this was awesome. And even for someone like me that's in the medical field, obviously, right? I still learned a lot, which was great. And I think everyone should go out and get Dr. Alo's book. I'm going to get it myself because I need to read it. And I think this was really, really educational and informative. And I love watching you. I love watching all your stuff online, Dr. Alo. Keep doing that because it's great. And
thank you.
And we're going to keep covering a broad range of topics, me and Dr. Richman, and really try and dispel all these myths that are out there and everything.
Oh, well, yeah. So you can buy Mohammed's book on Amazon, and we're going to post it on the podcast at the end. and you can find him on social media. We will post that also. And, you know where to find Dr. Fiorillo and myself, two doctors tell the truth. And as you know, I do online lipid consultations at Paladin MDs, www.paladinmds.com. And other than that, I hope everybody has a great day. And this was excellent. This was excellent, dude.
Yeah, thanks for having me on. This was nice. It's nice to talk to
Thanks for
normal
coming. I
people that
enjoyed it.
aren't trying to sell you some nonsense.
Right.